Hello, CTSNet friends, and welcome to a very special CTSNet Beat podcast because the STS is getting kicked off right now. We'll tell you all about everything that's going on in that Los Angeles meeting, and also we have 3 great articles and 3 great videos for you on CTSNet. We've got some really amazing articles. We've got a meta-analysis about aortic valve replacement in asymptomatic patients. There is an analysis about the global workforce and women balance. And there's a really great article from EX all about robotic cardiac surgery. Some amazing videos for you this week. An amazing truncus arteriosus repair, a left ventricular mass removal that I would love to have removed myself, and an amazing tiny weeny pacemaker is put into a 2-month-old baby. So stick around and we'll tell you all about the news going on in the world of cardiothoracic surgery this week. Welcome to this very special CTSNet podcast. It's special because the STS is kicking off. Now, I've titled this podcast Balancing the Risks and Benefits of Undergoing the Meeting, because certainly there's been nothing else on the lips of pretty much everybody. Are we going to go? Are we not going to go? And I've certainly had quite a few meetings about this with some of the STS leadership and CTSNet, and I'm sure you have too, even in your own department and amongst your colleagues. And I think on reflection, I think the STS have done an absolutely fantastic job. I would encourage you to go to YouTube and look at Jennifer Romano's YouTube video describing their decision making to come to say that we should go ahead, and also some really good information on the STS website as well. But in summary, Jennifer has struck, I think, a fantastic balance. First of all, she does state that both her and her husband originate from Los Angeles. They know loads and loads of surgeons from Los Angeles. Joe Chikwi, Annals of Thoracic Surgery editor-in-chief, is in Los Angeles. So they've literally been talking to people on the ground. They've talked to the conference center. They've talked to lots of people to make the decisions they've had. Now, what is the difficult balance that they are making? Well, the difficult balance is, of course, because of the huge wildfires, because many lives have been lost, 100,000 people have been displaced. We in no way want to impact the recovery effort in Los Angeles. You know, we would not want to fill hotels with delegates from all around the world when they desperately need them for displaced people. We would not want to put pressure on the conference center with all their staff when they might be needing to move house or be at home or be thinking about their families. But in fact, on the other hand, how do you help Los Angeles? Well, if things are under control and if there is management plans for this catastrophe that is ongoing and these wildfires, then perhaps the best way to support Los Angeles is to do business as usual. You know, we've all had the experience of COVID and some other disasters, and actually it's getting places back on their feet that can be just as important, because stripping out benefits to the economy, making things grind to a halt can be just as disruptive. So in Jennifer Romano's excellent YouTube video, she does point out that they have taken extensive efforts to make sure that in no way are we stealing hotels, in no way are we going to impact the staff of the conference center. And in fact, she describes it as giving LA a big hug by coming and supporting. And I really support that. I think actually we can get very scared by the images that the newscasters show and all the horrific scenes, because those cameras are 10 yards away from the fires and the catastrophe. And of course, many people have lost their homes and many people have passed away. But actually, if we then abandon Los Angeles, everybody doesn't go there, the pubs, the restaurants shut down, the conference center staff don't get paid, the hotels lose money, and it doubles the cost of the catastrophe. So actually, I'm in full support of us as a worldwide community of cardiothoracic surgeries giving Los Angeles a big hug and going and having our meeting. The second thing she points out is the importance of having annual meetings. We come together once a year at each society, so STS, ATS and EACS, so that we can share ideas. And certainly I'm personally looking forward to going to the meeting next week so that we can talk to each other, we can share ideas, we can learn something. And every single meeting I go to, I learn something fantastic that I always bring back to my practice. If it's enhanced recovery, if it's how to deal with a complication, if it's a new paper that's just coming out that's going to change my practice. You often find it at the meeting. So Jennifer quite rightly says these are actually important meetings for us, and that helps benefit patients' lives worldwide. So that's a really good reason to have the meeting. She did also very nicely go through what else we could have done. Well, could we have just swapped out for another town or another city? There's actually a Super Bowl playoff that was going in LA, and they were thinking of just moving it to another city. Well, that's maybe easy for a single Super Bowl game, but actually for a conference, it's impossible, especially 8 days before. These conference agreements are signed 5 years in advance of the conference. So 8 days before, you're just not going to find a conference center ready to welcome the STS. And we can't change our flights. We can't change our hotels. You can't have 4,000 hotel rooms in another city that we can just use. A lot of people have been proposing going online. We did it in COVID. Why don't you just fire up the STS COVID app and just have a meeting like we did in COVID? Well, again, that took several months to organise. And in fact, as you know, COVID hit about March, and it was the STS 2021 meeting. So they had actually, months and months to prepare. And it just would not be possible to do this with 8 days to go. So really, the decision was abandon everything or go give Los Angeles a hug. And we're going to do that. And then the icing on the cake that fantastic Jennifer gave us was that they are going to contribute $100,000 to the relief fund. And they are recommending that everybody that goes to the conference also contributes to this fund so that we actually actively help by fundraising to help the recovery effort. So well done, STS. Well done, Jennifer. And I look forward to meeting you all in Los Angeles. We are actually going to probably hope to meet as many of you as possible. Information at the end of the video. But I would love to meet some of you. If you enjoy the podcast or enjoy CTSNet, then do come and say hi. We'll have a CTSNet booth and I will be there. I will post when I'll be there. I'll probably try and go there most lunchtimes. So just rock up, say hi, and give us any hints or tips or anything you want to do or videos you're thinking about. Come say hi. We've got a competition going as well. So if you're not sure whether your video might be suitable, then come say hi and we can tell you whether you might win $1,000 for your video. So it'd be great to see you there. We're going to try and do some content at the meeting. So if you're not coming to the STS, then don't worry, we will post a bit of content. But for those of you that are going, then just there's a few things. Let's tell you a few things that are going on because you might be there right now. You might be traveling to it right now. So first of all, there's an app, STS 2025 mobile app. Go check out the App Store. On the Thursday, there's 3 early symposia, lung cancer clinical trials coming into clinical practice. Lung cancer treatment's absolutely going crazy at the moment, all the immunotherapies and the perioperative therapies. Do you do immunotherapy pre-op or peri-op or post-op? Which drugs, durvalumab, nivolumab, pembrolizumab, which mAb do you use? And that's all going to be covered in the lung cancer symposium. The aortic universe sounds like a fantastic symposium. From birth to adulthood, everything you ever wanted to know about aortic disease is going to be discussed on that Thursday. And there's actually an STS app conference, redesigning the future together, working out innovative ways for apps to enhance our roles in cardiothoracic surgery. So I thought that would be fun. Remember the exhibit hall, so that's going to be there, and CTSNet will be there. There are going to be two really big keynote addresses, as well as the presidential address. So Jennifer Doudna is presenting the Nina Starr Braunwald Lecture. She is a Nobel Prize winner for her pioneering work on gene editing. There are some incredible CRISPR techniques going on and some phenomenal things going on. So it will be amazing to hear what is just around the corner in the world of gene editing from a Nobel laureate. I think that's a really great invitation for an amazing lecture. And the second really interesting and innovative invitation is for the Vivian T. Thomas Lecture. They have invited award-winning photojournalist and filmmaker Amy Vitale. She's an advocate of social responsibility, and she's actually going to tell us how storytelling can be a meaningful, positive influence on our staff. And we've all had experience of Shanda Blackman's amazing book, How to Engage with Our Patients. So I think actually this will be a really interesting talk to try and maybe take us out of our standard bubble of what operations best and try and think about how we engage with our patients or wider society, telling our stories of how our amazing operations are impacting lives every year that we do them. And of course, you can never miss the presidential address. Jennifer Romano, this actually is the first ever female presidential address that will actually be given. So do go, and it will be, I'm sure, posted as well afterwards. But there's nothing like seeing the absolute packed audience, because obviously it is always the highlight of every conference. There's going to be an STS TV channel. STS has paired up with Web's Edge, and they're going to do sort of magazine-style TV shows, so that should be really interesting. They're going to have a few people telling you the highlights and going through things. So have a look on the STS website to see if you can have a look at some of the STS TV. So that's some of the things that are going to be there at the STS, so hope I do see some of you there, and if I don't, then we'll have a talk about it on next week's podcast, Everything That We Found Out. But let's get into what else is there on CTSNet Week this week, and what big articles are there that you need to know about. We're profiling a really interesting article called Women in Cardiac Surgery, a Global Workforce Analysis. This is actually being published in the European Journal of Cardiothoracic Surgery. It's got multiple authors. Penelope Adinku is my favourite. I've worked with her in Accra in Ghana. She's a fabulous surgeon there. Lorena Montes, our very own cardiac editor. Alia Izumi, first author, and Dominique Vervoort. And it's a really interesting article because actually it highlights that in Western society these days, in the world of cardiothoracic surgery, and this is a really big analysis. This is analysis of 14,651 people in the cardiothoracic worldwide workforce. And in America and Europe, about 1,000 of them are female. So North America have the highest stats in cardiothoracic surgery, 11%. They do point out in the article that that's still terrible, way, way worse than cardiology, pediatrics. We are really bad at diversity in our specialty. But the impactful thing in this article is that wait till you go and see other places in the world. East Asia, 2.9%, Middle East 1.9%, and Africa 1% or less, literally Penelope. So there's a long way to go in the West, but there is a huge mountain to climb for diversity in the rest of the world. And I hope bringing societies like the WTS and many others to high profile should go some way to change that. Because, of course, if nothing else, half our patients are female. So great article there. A very, very different article now. Really good quality article. This is entitled European Association of Cardiothoracic Surgeons Future View on Robotic Cardiac Surgery in Europe. So this is written by the EACTS Innovation Committee together with the EACTS Robotic Surgery Task Force. We profiled the new guideline for creating guidelines last week. So STS, AATS and EACTS have come together saying there are three types of guideline. So proper full guideline, expert consensus, and task force reports. And this kind of doesn't really fit into any of these, so I'm not sure what kind of article this is. It's a sort of position statement or future vision, but I really like it. It's a really good article that is basically just trying to set out what we hope the future of cardiac surgery is going to be. It's obviously got every single, amazing high-profile person as a co-authorship group. It doesn't actually set out to try and provide guidelines, so it's not a guideline. It's not telling you must or you should. It's actually not saying how to do it safely. It's just laying out, where we are at 2025 and perhaps where we should be. It points out the fact that, these days mitral valve repair is more and more minimally invasive. Mostly it's not robotic. Mostly it's thoracoscopic minimally invasive mitral. And in America, minimally invasive CABG with robotics is taking off. But it really isn't taking off very quickly at all in Europe. But they do point out that we already have papers showing reduced post-operative complications, reduced pneumonia, reduced pain, shorter recovery times with minimally invasive CABGs. But more interestingly, they talk a bit about how it influences your heart team meetings. Providing the option of minimally invasive or robotic CABG changes the way you talk about whether you're going to have a Lima to LAD or PCI to that LAD. Because if you've got a minimally invasive approach, there are multiple papers now saying that people prefer to offer the option of a minimally invasive Lima to LAD rather than a PCI. So I thought that was really interesting. And once you are discussing the single vessel minimally invasive CABG, then again, the heart team approach starts to move towards multi-vessel minimally invasive revasc as your experience grows offering this minimally invasive approach. So they make a really good argument for bringing it into your practice, changes the heart team discussion. It offers more patients a very long-term solution to the stenosis in the LAD and other vessels. And actually, your interventionists do often come with you when they understand that it is a quicker recovery and less invasive for the patients. And they talk about it no longer being a black or white decision because you've got this continuum of stenotomy approach, minimally invasive approach, or PCI approach. So I really like that as a concept, which I thought was good. They provide some statistics. Apparently 15% of all mitral valve repairs are now done minimally invasively in the USA, and that is growing, which I thought was interesting. And all in all, I thought it was an excellent paper. They also show the EACS robotic training course. They had some really good virtual reality. They had a rods and cones simulation, rods and cones link up to a real case. And they had a bit of sales for the EACS robotic training course, which I think does look fantastic. And they also did a bit of a thumbs up to the Francis Fontaine Fellowship for Robotic Surgery. So, and talk about Laura Besola and Rafik Marjarian, who both received full training in minimally invasive revasc surgery. So EACS are doing a lot to try and kickstart robotic surgery in Europe, and so big congratulations to them for doing that. Here's a huge paper that you have to read. Aortic valve replacement versus clinical surveillance in asymptomatic severe aortic stenosis, a systematic review and meta-analysis. This is huge. This is practice changing. This is heart team changing. And you need to know the outcomes of this paper to discuss with your cardiologists. The first author is Philippe Généreux. He's actually also one of the first authors of one of the 4 big randomized trials in this area. And Mark Dweck is senior author, and this is in JACC, Journal of the American College of Cardiology, a big journal. So what did they do? They did a systematic review, and basically they found the 4 big RCTs. What are the 4 big RCTs? There's a paper published by Kang called Early Surgery or Conservative Care for Asymptomatic Aortic Stenosis, published in the New England Journal of Medicine in 2020. The Avatar trial was published in the European Heart Journal in 2024. Aortic valve replacement versus conservative treatment in asymptomatic severe stenosis long-term follow-up. In the New England Journal of Medicine 2024, Philippe Genereau's paper was published, and that's a transcatheter aortic valve replacement for asymptomatic severe. And the fourth one is called Evolved in JAMA 2024, early intervention in patients with asymptomatic severe aortic stenosis. Of note, 2 of them are TAVR and 2 of them are mixed, and I don't think that's important. And actually, there is a sub-analysis showing that actually it isn't important whether it's TAVR or SAVR. Subgroup analysis shows no difference between the SAVR and TAVR approach, so that's good to just kick off with. But what did they find? Well, the 4 ICTs is 1,427 patients, so this is big numbers. So 719 in the early AVR group and 708 in the conservative treatment. What did they find? Well, 4 years of follow-up and a significant reduction in unplanned cardiovascular or heart failure hospital admissions. And that's 14% versus 30%. So that's a big difference. Over 4 years, you're more than halving the chance of them having to be rushed into hospital with a nasty, bad problem. There's a reduced rate of stroke, 4 versus 7. So 5% difference in stroke if you get in there early. There isn't a statistically significant difference in all-cause mortality, although the difference in the group is 9.7% versus 14%. So the p-value is 0.17. So actually, there's only there's a 17% chance that those differences mean that it isn't really a difference. So actually it's trending towards a difference. If there was a 5,000 patient trial and those changes were like that would have been a mortality benefit. And so actually, what's the finding of this? Less hospital, half your hospital admission rate afterwards, reduced stroke, and there's a trend towards improved mortality. So I thought that was really impactful. We previously covered some of these trials, and actually the really interesting thing is a huge number of the conservative group end up going and having an AVR in the subsequent years. I just, off the top of my head, it was something like 80% or something. So actually, that's the other thing we should be discussing. These asymptomatic severes sooner or later will be coming for an AVR. So really interesting. I do encourage you to try and get your heart team to discuss this paper and even go to get those 4 key trials out, because I think that is huge game changing if we start going into the world of the asymptomatic severes. The next paper we thought is a thoracic paper. So this is done by my good friend Andrea Bile, who's in Glasgow, and also Ashkay Patel, who's also a super cool guy and actually helped to train him in robotics. And they have looked at the STS surgical database for thymic tumours. This is called robotic assisted versus VATS surgery for thymic epithelial tumours. So it's looking at the VATS or robotic approach for thymomas. This is published in the European Journal of Cardiothoracic Surgery and really highlights this fantastic database. So the STS have got 82 centres inviting to participate, 37 have got submitting their data, they're big centres, and we've got 899 cases in there. And to cut a long story short, median age 55, and they did an analysis, and basically 366 they analysed that had VATS approach, and robotic 366. They did propensity match analysis. And the long and the short of it is, if you do it robotic assist, you have a significantly lower chance of an incomplete resection, and that's it was quite a big difference as well. So there was actually 5 times less R1s in the robotic group. So a really big thumbs up to doing it robotically versus VATS. You get better vision, you can do it more meticulously, you can be more extensive, and although they did say in that there's no difference in terms of overall and disease-free survival in the course of the trial. And actually, it's a 20-year database. They do have some quite long survival. So that was really interesting. Well done, Andrea Bile and Ashkay Patel. So those were our articles, and of course we have 3 great videos for you. We're actually going to come to the STS to talk about what makes CTSNet great. And last week we also had a bit of a deep dive of what is there, and really the long and short of it is that CTSNet is about videos. They're about the wonderful and interesting, fascinating videos that you guys send to us that we provide for free with no passwords, with no logins. We don't even need to know your name. You just come and watch our videos. And I just find them fascinating. Remember, I'm a thoracic surgeon, used to do cardiac as well, but I'm a thoracic. And yet I was fascinated by this first video, truncus arteriosus repair with the modified Barbero-Martial technique, with reconstruction of the neopulmonary valve with the right atrial appendage. This is by Mahmoud al-Baghdadi and Ahmed Quadoum. They're at the Al Nas Hospital for Children in Egypt, and it was fascinating. Basically, it's a little 2-month-old kiddie with a truncus arteriosus, a common trunk. They did a really nice explanation showing the echocardiogram, showing that the pulmonary artery and the aorta are just one. They then did a really good video. First of all, opening up a big hole in the right ventricle, patching the VSD, opening up the truncus arteriosus. You could then see the pulmonary artery, and you could see separately the arch of the aorta. They then put a big baffle between the two. They then diverted one off the new left ventricle going down to where the aorta should be, and then they demonstrated how you could reconstruct the pulmonary artery. And the clever thing was they snipped off the right atrial appendage and they turned it into a pulmonary valve. How cool is that? We have done some other videos actually of turning the right atrial appendage into a tricuspid valve as well. I do find it very clever how you can do that for a right atrial appendage, but they show it right in front of your face. Beautiful job, and I really enjoyed that video, and I hope you do too. The second video made me want to go and do the operation straight away. This was fun. This is called the Redo Endoscopic Left Ventricular Mass Removal. This is a video of an 81-year-old guy who had had CABG before, and then suddenly he has a super rare sarcoma. So he had his sarcoma removed from his left quadriceps. He had another myxoid sarcoma removed from the left carotid artery, and then they find a big round blob in his left ventricle. The imaging in this video is just fantastic. You could even publish this without the operative video because they've got the echo, they got the cardiac MRI, they got a reconstruction, they show you where the grafts are, and they've got this beautiful blob just bouncing around in the left ventricle, looking like it's going to fly off at any second. So they do a right chest approach. They've got a really groovy retractor for the mitral leaflets, and then they bob straight into the left ventricle, put a few sutures in the sarcoma to give it a bit of a tug, and then just snip it off the papillary muscles, and out it plops. I would love to have done that operation. Probably one of those once-a-career operations, super rare, but really fun, and a great little 10-minute video if you've got time to have a look at that. And then the third video is super fascinating. I did not even know this could be done. So listen to the title of this: the implantation of a modified micra for a pediatric implantable pulse generator for epicardial pacing. So this is by Benjamin Alexander and Lawrence Greeton in LA. Maybe you could meet up with you guys next week just to say what a great job this is. So what was the problem? Well, this was a 23-month month-old infant diagnosed with pentalogy of Cantarell with ectopia cordis. So they had a double upright ventricle. They had to have surgery to repair this, which is not in the video, but basically they post-operatively caused a complete heart block. So the poor little 23-month-old child has now got complete heart block. Now for us adults, it's fine, just bang in a pacemaker. When you're 23 months old, you're too small for a pacemaker. And actually, I have a pacemaker charity. We send out 600 pacemakers a year to the developing world, and I don't have a small pacemaker. I have once sent a Micra to Nigeria to be inserted in a child, but that child was 5 years old. So Micra made by Medtronic is the very smallest pacemaker that exists, but even with that, it was too big for this child. So what did they do? Well, amazingly, they contacted Medtronic. Medtronic modified the Micra to make it even smaller. They basically took all the parts and put it in a one-off bespoke housing. They got FDA exceptional approval to use it as for compassionate use as a one-off. They then did a left fifth space mini thoracotomy, dissected down to the right ventricle, put two standard epicardial pacing wires on, although maybe they were smaller than usual. Have to just check that one. And then they inserted it into this modified Micra and made a pocket and basically saved the life of this 23-month-old kid by approaching technology, approaching Medtronic, creating a one-off device and using that to save the life of this kid. Absolutely phenomenal, great job, and just, didn't even know that could be done. So definitely worth 10 minutes of your time to have a quick look at that video if you fancy it. So those are our videos and our articles. Hope you've enjoyed them just like I have. And just as well as the STS, there are a few other things coming up on the calendar. If you're enjoying being in Los Angeles, then on the 30th of January, there's a Controversies and Advances in the Treatment of Cardiovascular Disease in Beverly Hills. That's by ProMedica, and we've got a link in the show notes below. EACTS have got a next generation webinar called Developing a Career in Cardiothoracic Research. These are absolutely fantastic. EACTS do a great job of these. This is January the 30th. It's online. If you're an EACTS member, it's free. I think it's like $10 if you're not an EACTS member. So it's really good and very worth logging in. So do check that out. And the STS have a clinical skills centre in Hungary, and it's called Open Access for Conversion of Difficult Pathologies course, and that's January the 31st. So do check that out. And it's Joseph Furak, ESTS ex-president, who's actually running that course. So we are coming to the end, but I would just like to give a shout out for the instructional video competition. This is now officially open. If you've got a video that you're going to be submitting to us, it's probably doing instructional teaching, so it's suitable for this competition. But together with Vince Gaudiani, we want to highlight and profile videos that are particularly good at teaching people worldwide how to do the procedure. So that's the point of it. Usually we get about 15-20 people applying for our competitions, but there is a $1,000 first prize. So if yours is a banger, it might well win, so send it in. And remember, we have just done the absolutely wonderful Unifying Revascularization Guidelines Across Continents and Specialties webinar with the wonderful Faisal Bakeen, who discussed with cardiologists, cardiac surgeons from Europe and America what the guidelines should be for revascularization. And we're going to post that online, the webinar in full, on the 22nd of January, so do check that out. So we're at the end of our podcast, and it's a big welcome to our VIP club. As you very well know, the VIP club is here purely for people that listen to the end of my ramblings, and it's as a big thank you. And so all you have to do to join the VIP club is send me a WhatsApp message on +44 780 154 8122, just as Michael Go did this week. week. Hi, Michael. Thanks for joining the VIP Club. You're a trainee in the Philippines, super enthusiastic, and so best of luck in your career. And if you're coming to the STS, come and say hi. Also, I'd like to say hello to a Carl Hallam. He's actually a retired doctor, but he tells me he does listen all the way to the end of my podcast. So here's a little test, Carl. If you are listening to the end, send us a text and I'll make you a member of the VIP Club. And here's a little post for my VIPs. If you're going to be at the STS, then we are posting on our VIP Club that we think we might have a little meetup. I'm thinking between maybe a little 6 o'clock on Saturday, or the alternative is I'll probably post on the WhatsApp group when I'm by the CTSNet booth. I'll probably try and be there each lunchtime maybe on the Friday and Saturday, and so maybe come and say hi. It'd be lovely to meet you in person and shake your hand. So what I'll do is I'll probably post on the WhatsApp group, so do check it out, see where the hell's Joel, and then just come up and say hi. It'd be great to meet you all and see you in person, and maybe we'll take some selfies. So everybody that comes up and says hi, I'm in the VIP Club, will take a selfie and we'll post it on the group. That'll be a bit of fun. So see you all. And I'll see you in the next edition of the podcast, which probably be from Los Angeles airport. And I'll tell you how we got on and how many of our wonderful friends we met together.